Welcome, dear friends, to today's presentation, which is talking about erectile dysfunction. Okay, so under the erectile dysfunction, it is a series of sexual disorders. Okay, so it's very important that this series actually will much concentrate on the aspect of sexual disorders. Sexual dysfunction disorders, in particular looking at approach to a patient with erectile dysfunction, part 1. Okay. So saying of the wise, very important to quote Sir William Osler, who always makes an emphasis that actually we can't practice medicine just by reading books. We can't practice medicine just by seeing the patients without having studying, without training, without going to training, without being mentored. So it says that to study the phenomena of the disease without books is to sail uncharted sea. To study books without patients is not to go to sea at all. Okay, so for you to really say you are practicing medicine, you have to ensure that you have got theory and you have the practice. So when you're combining these two things, that's when now you are practicing. Actually, in practice, we understand the theory application very well. Okay. Let's look at the outline of the study. We're going to look at the definition, epidemiology, anatomy review, physiology review, causes, risk factors, pathophysiology, and we'll look at the approach to diagnostic framework. We can begin. How do you define? By the way, before we define, what are we able to see here? We are seeing an embarrassment. So we're looking at how best can you handle this situation that you are able to see here. Okay, we can see a female is pointing somewhere there. Okay, there's something there, and then there's a problem here. Okay, so this is a lecture for today. Let's proceed and look at the overview. So how do you define erectile dysfunction? So erectile dysfunction is a persistent failure to achieve a penile erection suitable for sexual intercourse. So when we look at this definition, it's supposed to also have a demand for how long should be this persistent. Okay. For how long should be this persistent failure? At what point do we call that is erectile dysfunction? So that is very important. So we'll find that actually the persistent is about minimum of 3 months, okay, to 6 months. So erectile dysfunction is the persistent failure to achieve or maintain a penile erection suitable for sexual intercourse for a minimum of 3 months. But a profound marked erectile dysfunction, it is when there's failure for 6 months. Now, it's also very important that I can give a quick classification of sexual disorders just to have an idea. I'm sure some of you are also undertaking clinical psychiatry. Okay, so classifications, we have gender identity disorders. These are also sexual disorders. Psychological and behavioral disorders that are associated with sexual development and maturation. Paraphilias, these are disorders of sexual preferences, and sexual dysfunction. So for today's lecture is not talking about gender identity disorders, it's not talking about psychological and behavioral disorders associated with sexual development and maturation, or paraphilias, but it's talking about sexual dysfunction. Now, for us to understand still the general view of sexual disorders, it's very important also to make a quick review on the normal human sexual response. So, what is the normal human sexual response cycle? It has 5 phases. Number 1 phase, it is appetitive phase, excitement phase, plateau phase, orgasmic phase, and resolution phase. So the appetitive phase, here the person should have interest, okay? Should have interest, should have the fancies, okay? The expectations about the sexual activity. Thereafter now, there should be excitement. That's when now there will be erections, okay? There will be physical, anatomical response and physiological response, biochemical response to sex, okay? That's the excitement. Then a maintenance of this excitement is what is referred to plateau phase. Okay, so orgasmic is now where now the orgasm the patient has reached now means ease of patient. Sorry, this person now has reached orgasm. Okay, there are some lubrications. All right, happening. Then thereafter a resolution phase. So this is a normal human cycle response to sexual. Okay. So any deviation, any problem with any of these that are mentioned, then that is a disorder. So now, when we look at what I've talked about, I talked about the second one, excitement, and the third one, a plateau phase. So the sexual dysfunctions today, I'm going to look at disorders of excitement and plateau. Okay, so the disorders of excitement and plateau, these are the sexual arousal disorders of failure of genital response. Okay, now when we are talking about that, what are we talking about? We are talking about male erectile disorder, which is usually dysfunction. Okay, so this disorder is characterized by an inability to have or maintain or sustain penile erection till the completion of satisfactory sexual activity. So this is where the issue is now. So hope we have defined. And this inability, this disorder should be at least for 3 months, and a profound one, 6 months. Okay. Let's proceed now. Talk about the epidemiology. So when we talk about epidemiology, we find that this now sexual dysfunction is not just affecting males, it is also affecting females. In females, it is 43%. Males, 31%. Okay. And some of the breakdown, you find that vesicular actually is covering 40%. Diabetes, 30%. Medications, 15%. Pelvic surgery or trauma, 6%. Neurogenics, 5%. Endocrinopathies, like those affecting the pituitary gland, hypothalamus, 3%. And then talk about idiopathic causes, 1%. Okay. Let's look at a quick anatomical review. So there we can see that this is actually overview structure of the penis. Okay, so when we look at here, we can zoom it bigger so that we're able to see what's happening. So when you look at these, this is what we are calling, there are two, we have this one and this one. So this one, it is called corposa cavernosa. Okay, this is the one that is very rich actually in phosphodiesterase, okay, which we're going to talk about. And then we can see that actually from here, this is a deep dorsal vein. We also have this one, we can see This one surrounding the urethra there. This one is called the corpus spongiosum. And there we can see that's the urethra. And then we can also see the cavernosa artery there. Okay, this is called the cavernosa artery. Okay, supplying blood, nutrients, oxygen. Okay, then we can also talk about the venues. These are called the venues. So to look at physiology, actually, we'll find that this is where we have to understand. So how does erection start? So erection is initiated by the dilation of the arterioles of the penis. These are the arterioles. Okay. So when these are dilating, okay, meaning they are receiving enough blood. Okay, that's the initiation. So as the erectile tissue of the penis fills the blood, this is the corpora cavernosa. Once it is filled with blood, then what does it do? The veins are compressed. These veins are compressed, and the compression of these veins blocks the outflow, and this blockage of the outflow actually adds to the turgor or turgidity of the organ, which is the penis, that resulting into the erection, resulting into increasing in size. The integration centers in the lumbar segments of the spinal cord are activated by the impulses in afferents. Okay, these are coming from the genitalia, descending tracts that are mediating erection in response to what? Erotic psychological stimuli. Okay, after someone has seen something and is attracted, then is excited, and that's the pathway. Okay, now the efferent parasympathetic fibers, these actually are in the pelvic splanchnic nerves, and these splanchnic nerves are called nervi erigents. Okay, and these fibers, they release acetylcholine. So when they release the acetylcholine, as well as the vasodilator, vasoactive intestinal peripeptide, which is written as VIP. These are called transmitters. It's also very important to take note that the non-adrenergic, non-cholinergic, these actually fibers are also present in these, the pelvic splanchnic nerves, which are called nervi erigents. Okay. Now, they are very rich in nitric oxide, and on the nitric oxide synthase, which is an enzyme. So they are very rich, okay? And we know that this enzyme, it catalyzes, okay, the formation of the nitric oxide. And the nitric oxide, it activates the soluble guanylyl cyclase. This is an enzyme. This enzyme results in increased production of the cyclic guanosine monophosphate. And this cyclic guanosine monophosphate, it is very potent vasodilator. Okay. Now, since this one is very important, then we should know that the nitric oxide synthase, it actually promotes erection. And if this nitric oxide synthase is inhibited, okay, then it will prevent the erection, okay, which is produced by what? Stimulation of the pelvic nerve, all right? Now, we have seen one principle here, that the nitric oxide plays a prominent role in the production of erection. That's why on the market, there are drugs like Blue Diamond or Viagra, which is also known as sildenafil citrate. So when we look at drugs, they inhibit the breakdown of the cyclic guanosine monophosphate by the phosphodiesterase, which are written as PG5. Okay, so now this actually the PG5, they are inhibiting the cyclic guanosine monophosphate. So now when we come up with a drug that is inhibiting, blocking the phosphodiesterase, it means we are promoting to increase the cyclic guanosine monophosphate, leading to actually the what? The erection. So now, this cyclic guanosine monophosphate, they are found here in the what? In the corpora cavernosa. Now, if these drugs like sildenafil citrate are increased, they also inhibit the phosphodiesterase type 6, which is found in the retina. So that's why one of the side effects of these drugs, it is to do with transient loss of the ability to discriminate between blue and green. So they'll be able to see blue, green color when they take such drugs. But I'll explain that in detail. So I've covered even the physiology. Okay, as we look at it, that's what happens. But a normal, we should know that it begins with what? Sufficient libido, ability to achieve, maintain penile erection, ejaculation, and maintenance. But that's what we should know. Okay, so libido refers to sexual desire, and it is influenced by variety, by seeing others. When they see some breasts, they see nakedness, they will have that libido increase. Others, just by smelling a perfume of a lady, they will feel sexy. Tactile, auditory, just by getting smooth voices. Others by imaginating or hormone stimuli. These are the key things. Also, sex steroid, like testosterone, we know it's a known hormone to increase libido. Okay, and we know that since desire, appetitive phase is what stimulates libido. So it can be affected by emotional context, systemic illnesses, hormonal disturbances, psychiatric disorders, and medications. Let's look now on the causes. We have primary, secondary causes. Primary, we mean someone has never experienced an erection. Secondary, someone have been experiencing erections, but now there's a problem. We can also talk about organic causes. These are the ones that are actually linked to physical problems. We can also have psychogenic causes. These are the ones that are dealing with the neuropsychological problems. They are non-physical. And then we can also talk about erectile dysfunction with reduced libido. The causes can be hypogonadism, it can be depression. We can also have where one has got intact libido. The causes can be psychological problems. We can talk about vesicular insufficiency. We can talk about neuropathic causes. We can talk about drugs. Okay. The risk factors of erectile dysfunction includes advanced age, okay, as a risk factor, alcohol, repeated drug use, sedentary lifestyle where someone does not do exercises, so they are becoming obese, okay, so that is a risk factor. Chronic kidney diseases, that actually affects to about 50%. Many patients who have chronic kidney diseases, actually 50% of them, they have erectile dysfunction. Coronary artery disease, the association here, it is the atherosclerosis, okay, that will result into depreciating the good flow of blood to the penile organ. So you find that the penile arteries actually are affected. So that is how the coronary artery disease is coming in. The pathophysiology, actually, we know that it is resulting from abnormality in any of the four systems for normal penile erection or combination. We can talk about the vesicular. Okay, so if the flow is bad, that can lead to erectile dysfunction. The nervous, we talk about, is a problem maybe with the pituitary gland, there's a problem with the hypothalamus, there's a tumor there that can also lead into erectile dysfunction. Okay, hormonal, we can talk about reduction of testosterone there, or hypogonadism, primary or secondary, that can also lead to erectile dysfunction. Sometimes, not even sometimes, patients' psychological receptivity to sexual stimuli. Okay, what makes this patient enjoy sex? What attracts? So that's psychogenic. Okay, social habits, smoking, alcohol, all that can lead, drugs, medications, that also will affect, as I've explained. Okay, now the issue is that there's a problem, not actually parasympathetic, but it's parasympathetic nervous system. Okay, so the parasympathetic nervous system is affected, as explained. So if there's maybe some drugs that are inhibiting the parasympathetic splanchnic nerves, okay, reduction of nitric oxide, meaning to not be released. So once this is not released, then it means the erection is reduced. Okay, when it is released, it's going to increase the inflow of blood in the corpora cavernosum. That will lead into the erection. So when there's a problem here, then it means the ED is there pronounced. Okay. The diagnostic approach framework is very important. So we have to talk about the neuro input. So when we talk about the neuro input, what is the neuro input? What are factors that are talking about the neuro input? So talk about psychogenic, tactile stimulus. Can talk about the nocturnal erection. We'll talk about the nocturnal erection are dependent on rapid eye movement, sleep, and we know and talk about sleeping. Sleeping has got also cycles, and that will be lecture that you can access to my lectures under the clinical psychiatry. Okay, so we know that we have the non-rapid eye movement, step 1 up to step 4. Then we know that every 90 to 100 minutes, okay, the a REM has to occur, and this REM has to occur at least 4 to 5 seconds throughout the night. Okay, that could be another lecture. All right, but this one also, the neuro input, when the psychogenic, tactile, the nocturnal erection, these are okay, they will lead also into erection. The other one that we may talk about is the blood arterial flow. Okay, so that is because it is required for sufficient intravascular oxygen, nutrients, and nitric oxide. That also will lead to erection. The other one is hormonal, which is testosterone, which also will lead to erection. Okay, let's now talk about this patient in detail on the diagnostic. What should we be looking for when we are trying to now see a patient? So here's a patient. Now you're trying to check the patient so that you can establish proper rapport. And remember, it's very important to ask the patient relating erectile dysfunction, because it is underdiagnosed, then it's also undertreated, or they will abuse drugs, okay, and they will not be responding, hence some will even develop some dependence. So we'll talk about organic. So we talk about organic, as I said, these are physical causes. So we have the neurogenic. So when we talk about neurogenic, we have to check for spinal cord injury, stroke, multiple sclerosis, peripheral or autonomic neuropathy. We can also talk about vesicular. Under vesicular, we'll talk about atherosclerosis. Okay, we may talk about diabetes, we may talk about smoking, we may talk about hypertension, we may talk about hyperlipidemia. Okay, so all these are things that we should inquire on the vesicular that are able to affect the vesicular system. The other, it is hormonal. So hormonal, it is any form of hypogonadism. That's talking about the low testosterone. Okay. So it can also be primary or secondary. And when we talk about primary, meaning it can be chromosomal or genetic related problem. And then that can be examples of bronchitis, testicular injury. We can talk about varicocele. Okay, so all these are the ones that we can give an example of primary hypogonadism. Then if there's secondary hypogonadism, that is actually the problem is the pituitary or the hypothalamus. Okay, so those are pituitary hypothalamic disorders. Medications also, although these sometimes in clinical practice they are separated as a cause, and the important medication that actually we have to know are antihypertensives like thiazide, beta blockers, clonidine, spironolactone, and also we may talk about antidepressants as well. We may also talk about anticholytics, and I'll come and explain in detail when I'll be talking about therapeutics. Okay, so don't miss part 2. Then other factors could be local factors. So the local factors, they can be either penile related or pelvic related. And examples of penile related, we can have the peroneal disease, okay? And this actually cure depends when erect, okay? And that's what we can talk about peroneal diseases. We can also talk about maybe there's a penile fracture. So this is usually what happens. And then we can talk about pelvic, prosthetic surgery, pelvic radiation, competitive cycling, okay? As we know that this is very common, bicycles, okay? So when young men are riding bicycles for more than 3 hours, so that simply means actually it can lead into as a log factor to lead to erectile dysfunction. The other part is psychogenic. So when we talk about the psychogenic factor, so the psychogenic factor that's now relating to neuro psychological factors. So number one, the causes can be pre-existing psychological disorders, okay? That you can talk about anxiety, mood disorders like depression. Sometimes you may find that there's a problem with interpersonal difficulties between the sexual partners. That could be like marital conflict or relationship conflict that can lead into psychogenic erectile dysfunction. They're not talking to each other. So meaning that they don't need each other. There's no stimulus. There's no drive. Okay. Then the other point that is there is sexual dysfunction in a female partner. So the other partner, like the female, has no feeling. So it's like the man actually is predictive already to say, there's nothing that's going to happen. So that can also lead to erectile dysfunction psychogenically. Okay, so the man will say, there's nothing here. Okay, she always doesn't respond, she doesn't entertain, and so forth. So that will lead into psychogenic erectile dysfunction. So the man will not have that appetitive phase, there'll be no excitement. So erection will not be there. Okay. The other thing is the infertility. So when you talk about infertility, the man may be discouraged to say, even if I have sex, my intention is to have children. So even if I have sex, there is nothing like such equals not having. That also will lead into psychogenic erectile dysfunction. Timed intercourse, there are times maybe for students or those distant relationship, couples that are intertown. When these are timed, whenever school closes, at the end of a semester, at the end of a term, that's when I'm going to have sexual intercourse. So such kind of situations can lead also to psychogenic erectile dysfunction. Infrequent intercourse almost they are in the same way because they don't meet regularly, okay? So that also will lead into the erectile dysfunction that's of psychogenic nature. Sexual abuse in childhood, usually these are traumas that will remain. So whenever sees anything relating to sex, will remember what happened, and that will actually remove the affective. Okay, and that is one of another cause that you should talk about in your screening on this patient. Also look about socio-economical conditions. When there's a reduction of income, okay, in homes, money is the problem, income is reduced, or there's professional stress at work, a lot of things to do, things are not moving very well, that can lead also to psychogenic erectile dysfunction. Okay. Again, I may give another example of performance issues. So performance issues, that's why you find fear of failure, performance anxiety, to say, no, balambwena more, I've been hearing about stories as a man, you should be so strong, and they will be defeated by that fear to say, no, actually she respects me and she thinks I'm too strong. So if I become so weak or I fail, I think I don't want to be embarrassed. So such also can lead to that. So as you are screening, be open, make a very good rapport when you're screening such patients. Then ignorance regarding the sexual act. Okay, you have never been taught, you are not sure if you know or you don't know. So that may disturb the morale. Okay. Masturbatory anxiety also. Okay. So you find that you need something to stimulate. So the masturbation also affects psychology. Okay. So that may have a negative impact when it comes to erections during the normal relationship. Fatigue as well. Okay. So you have to find what kind of work, how many hours, time spent. So fatigue. So after the day of hard work, you don't expect this man to have good erections, needs rest. Okay. Fear of pregnancy or STIs. Okay. Thinking maybe I may pregnant her, I may contract an STI. That mindset during the occurrence, during the preparation, only find that someone is offset of the game. Okay. And that may just find someone erected, but the penis has dropped down. So that can be maybe fearing. The other one is fear of damaging of the sexual partner or oneself, especially if there are other related conditions, especially in female, there's no orgasm, or the man appears to be huge and the girl is slim, that can say, maybe I will injure her. So that taking care may also affect the psychology. Then other thing also is certain environmental factors like lack of privacy. Okay, so look, I cannot have here. No, here will be seeing, and they are shy. So that can also lead to psychogenic. The other part also is a lack of a confident sexual partner to say, maybe I'm not strong, maybe I cannot satisfy her. So that will lead into psychogenic erectile dysfunction. The other one also is fear of commitment. This is very common. Mainly, you find that those who are not yet married, they are scared to say, once I have sex with her, she'll be following me, and I'm not yet decided if she's the one I'm going to marry. So I don't want to find myself that actually I've impregnated her, then she'll tell me, no, since you have had sex with me, you have to marry me. So they are scared of that commitment. So whenever they meet, there's something rotating their mind that will affect actually the psychogenic. The other thing also, those who are married and then they are having extramarital sex relationships. So they're also scared to say, if I happen to have sex with this woman, maybe she'll be following me and she may bring problems with my wife, she may bring problems with my family. So that whenever they are there, the man will not show that interest, and that will result into psychogenic erectile dysfunction. Hope this has been so clear, dear colleagues, that there are a number of things that you can talk about psychogenic. Okay, now let's look on the aspect of the diagnostic. What do you do the assessment? Okay, that's very important. So the key diagnostic assessment will include the erectile dysfunction severity, so that you need to know how severe it is, and then the medical history, the underlying cause, surgical history, current drugs, and talk about now current drug history, talk about the physical examination, laboratory tests, and imaging studies. That is very cardinal to do. And let me try to look at the aspect of the approach. So first thing, you need to look at when assessing the patient presenting with erectile dysfunction, history taking at least include the time course. For example, the age of onset, duration, progression, is it rapidity of onset, how did it start? So that you need to do a very good history, okay? And when you talk about situational factors, also you need to know that erectile dysfunction only occurring in specific situation that may be indicative of psychogenic, as we have just explained. Okay, and those that are not during, for example, let's give an example of like erectile dysfunction happening with a partner, but not during masturbation. You know, still that is psychogenic. So that's what you need to know about the situational factors. Okay. Sexual history is very important. You need to look at frequency because we have just discussed to say infrequent can lead to psychogenic. So how often? You need to talk about the libido. Do you have desire? Presence of relationship problems. Are there some problems in the relationship? Okay, with a partner. Any history of sexual trauma. Any history of disappointments. Okay, that can also affect. Quarrels, fights, okay, all these can affect. Occupational relation issues, like maybe at work, there is pressure, all that can. So do a very good history taking. As you know that history taking will give you about 80% information. And in a situation you find that, no, dog actually have no sexual desire, then you know that the problem is either advanced age. Look at the age. If the person is young, think of reduced testosterone. Okay. Then it's very important also to interview the partner. That is if possible, of course, with the permission. Okay. So that you are able to rule out psychogenic. So you need to ensure that you engage the importance of handling as a couple. These issues of erectile dysfunction or sexual issues, sexual disorders, should not be dealt in isolation. They should be as a couple. Then you're a very good clinician. Okay. Then you need also to focus on genitourinary system, your history. Ask about prostate surgery history, pelvic radiation exposure, or traumatic trauma. Also ask about do you ride, are you a cycler, do you bicycling, okay? So that you're able to know how often, how many hours do you cycle, how many kilometers, how often in a week. That will give you an idea. Okay. Past medical history is very important that you can talk about it. I think we use the dates. You remember the dates as usual. We talk about diabetes, diabetes mellitus, and then we may talk about hypertension, we talk about hyperlipidemia, we talk about coronary artery disease, ask about chronic kidney disease. I think that's very selective and a must not to forget during your past medical history. I repeat, diabetes mellitus, hypertension, hyperlipidemia, coronary artery disease, chronic kidney disease. Okay, then ask about medications that we talked about, the antihypertensive drugs, antidepressant drugs, talk about psychotics drugs. Okay, so ask about drugs. Of course, don't ask the patient, have you ever taken antihypertensive? Check about BP and and you can assess by the dosage. They'll describe, these are beta blockers and these drugs are known. Okay. Visuals also very important in case they have a problem or they're abusing the drugs. Okay, as I mentioned about Viagra or Blue Diamond. Okay, so they're able to know what's happening. Then on your examination, the other thing also we may talk about. Actually, I've gone to examination. Let me before I go to examination. Substance abuse also very important. Yeah. Okay. Substance abuse, alcohol, cocaine, those drugs, smoking. So all these should be gauged. Now, when you go to examinations, so examinations talk about the visuals. Observe and see. Check the patient. Check the scrotum, the size of the scrotum. That's very important. And begin with the genitourinary examination. Going to talk about, are there some penile plaques, testicular size, okay, and peripheral evidence of reduced testosterone. You may talk about increased breast size, okay. So when there's gynecomastia, then you know that that's an indication of reduced testosterone on your physical examination, and that actually the patient may lead the patient to lose what? Libido. Assessment for evidence of systemic atherosclerosis, such as peripheral pulses, okay? We may talk about the cremasteric reflex. That also will help you, okay? And the absence of the cremasteric with erectile dysfunction, that will tell you that that is neurogenic etiology. Now, there is something very important we have to assess using standardized questionnaire, and that is to use actually the what? The International Index Erectile Function. That is very, very, very important to discuss. Okay. So the International Index of Erectile Dysfunction, one, you have to add your score, add all questions, break down into 5 specific areas of. Number 1, you ask on erection, orgasm, ask about sexual desire, which is libido, ask about intercourse satisfaction, ask about overall satisfaction. And the scores as follows. 1 to 10, it will give you the severe erectile dysfunction. 11 to 16, it will give you moderate erectile dysfunction. 17 to 21, it will give you mild moderate erectile dysfunction. 22 to 25, mild erectile dysfunction. 26 to 30, no erectile dysfunction. Now, let's look on the other part that is very important that we shouldn't forget about. It is the risk assessment. Okay, so complete a cardiovascular risk assessment before initiating erectile dysfunction therapy in men who are about 50 years or those at intermediate or at high risk cardiovascular disease. So what does it simply mean? So let me go just give you an idea so that you understand. Using the Princeton 3 consensus, there are 7 key areas that you're supposed to know. Number 1, take your pen. Age, hypertension, diabetes, smoking, dyslipidemia or hyperlipidemia, sedentary lifestyle, and family history of premature cardiovascular disease. So these are the key areas to take. So when you say low risk category, okay, that's the risk assessment. There are 3. We have low risk, intermediate, and high risk. So when you talk about the low risk category, that's asymptomatic and there are less than 3 risk factors for coronary artery disease, excluding sex. Okay. Then there is also mild angina, stable angina actually. Mild stable angina, okay? Or it has been evaluated and been treated. Uncomplicated previous myocardial infarction, left ventricular dysfunction, or cardiac congestive heart failure, New York Heart Association class 1 or 2, post-successive coronary revascularization, controlled hypertension, mild valvular disease. When these are present, okay, they are less than 3, then we know that is low risk. The patient is at low risk and is asymptomatic. When we say it's intermediate risk, then the risk factors for coronary artery disease, they should be more than 3, okay, excluding sex. Then they should be moderate, stable angina, and recent myocardial infarction, at least above 2 weeks, but less than 6 weeks. So 2 weeks to less than 6 weeks, that is intermediate risk, okay? And then the left ventricular dysfunction, or there is congestive heart failure, and then class 2 of the New York Heart Association, then we know that. The non-cardiac sequence of atherosclerotic diseases such as stroke or peripheral vascular disease, we know those are at intermediate risk. Then the high risk category, okay, we are going to find that they check for high risk arrhythmias like fibrillations, okay, check for recent myocardial infarction at least within 2 weeks. Then check the patient has unstable or refractory angina, the left ventricular dysfunction, or the congestive heart failure, New York classification, heart classification, stage 4. Okay. Maybe also you check for hypertrophic, obstructive, or any other cardiomyopathy. Okay, and controlled hypertension, moderate to severe valvular diseases. These are high risk. So that's what we mean by complete a cardiovascular risk assessment. That's very important. This is the International Index Erectile Function 5. That is very important to take note. Now, what does it mean? So you can see that it is equals 1 to 5 and using all those parameters. And these are the questions that you have. So you can pause the video and go through these questions. They're very simple to ask, and that's the standard that's supposed to have to a patient. Now, let me talk about interpretation of the same. Okay, that's very important. So how severe, when you're looking at this one, you're answering a question, how severe is erectile dysfunction? So the scores, when they are 5 to 7, then you add total of your 5 questions and they are giving you 5 to 7. That's indicative of severe erectile dysfunction. Okay? If they are in the range of 8 to 11, that's moderate erectile dysfunction. If they're in the range of 12 to 16, that is mild to moderate erectile dysfunction. If they are 17 to 21, that is mild erectile dysfunction. They are 22 to 25, actually, there is no erectile dysfunction. Let's now look on the aspect of the diagnostics. Whenever we see that sign, we're talking about the diagnostic. Okay, that's very important. So we have the laboratory investigations. Of course, you have to do the glycated hemoglobin. Okay, you also need to do the lipid profile. You need to do the complete metabolic panel, that is clinical chemistry. You need to do about the serum testosterone. Okay, you can do both total and free. You can also talk about prolactin, and I'll be able to explain when to do that. These are the luteinizing hormone, follicle stimulating hormone. Then you have imaging. Now, that's very, very important for a clinician to know. Okay, so on the aspect of testosterone there. It's very, very important that whenever testosterone is low, that's when now you can proceed to do what? The luteinizing hormone and follicle stimulating hormone. So it's not just about ordering all of them at the same time. So now I want to guide you if how to practice here in terms of ordering these others. Okay. Then when the luteinizing hormone, follicle stimulating hormone, actually they are high, okay, that will indicate to say that is primary hypogonadism. So now you have to determine the karyotyping, okay, so to evaluate chromosome abnormalities. But if the luteinizing hormone, follicle stimulating hormone, it is low or it is low to normal, then think about secondary hypogonadism, that to think about pituitary or hypothalamus problems. So once you find that it's pituitary or hypothalamic problems, then you have to proceed to do prolactin hormone. And then when you find prolactin hormone is very high, which you are calling hyperprolactinemia, then that's when you can consider the imaging. And that imaging is also going to guide you on the treatment modality. If it is less than 10 millimeters or 1 centimeter, that can be managed by the drugs, which at this point, I'm not going to talk about the drugs. I'll talk about that in part 2. If it's more than 10 millimeters, okay, or 1 centimeter, that has to do with the surgery. So that is very, very important. Now, on the summative aspect of investigation, it's very important that there are what we call routine or minimal investigation that should be done in a patient who presents with erectile dysfunction. Okay? There are also further tests and advanced tests. That's very important to take note. So let me begin with which one that I've mentioned are routine. Number 1, the routine investigations we can talk about glycated hemoglobin. It's a routine investigation. Talk about the lipid profile. That's a routine investigation. And talk about the testosterone. That is a routine investigation. So these are routine investigations. The rest there are supportive. We can even add full blood count, complete metabolic panel. You can add it. Those are just complementary. But these 3 investigations are very important. Now, lipid profile, you can do it, order it only if the patient has never been assessed in the last 12 months. Okay, then to be very necessary. Then the testosterone, this has to be done between 8 hours and 11 hours in the morning in a fasting condition. That is when you should perform this kind of a test. Okay, and an abnormal test for testosterone must be repeated at least after 2 to 3 weeks for you to really address your diagnosis. So once you find that actually now the testosterone, there's a problem, it is low, that's when now you have to do prolactin hormone levels. Okay, so I will be using colors. Hope you'll be able to follow. That's when you can do the prolactin. Okay. And when you find that you are suspecting something to do with hypogonadism, okay, you can now do the luteinizing hormone and follicle stimulating hormone. Okay, that is very, very important. Now listen carefully. When you do the prolactin hormone and it is actually increased, okay, it's increased, rather, yes, let me talk about prolactin hormones increased. Then you should talk about imaging here and do the pituitary MRI so that you know, is it less than 1 centimeter? You can handle it medically. Is it above 1 centimeter? It requires surgical intervention. Also, luteinizing hormone and follicle stimulating, if it is actually reduced, okay, then you know that that is what? Secondary. It will still lead you to do the imaging. Okay, that is very important. So those are what we call feather tests. Okay. You can also do serum estradiol, especially in a patient who has got breast symptoms, gynecomastia, no? And that patient, if that patient actually wishes to father the baby, then, and testosterone won't be used, you can test serum estradiol. It's not routine. Those are the content. Check for the breast symptoms. Also, you can do semen analysis, but it's not routine as well. But it should be done before testosterone replacement therapy. That is, if this man actually wants to have a child, but before you give testosterone replacement therapy, you need to know you can also do semen analysis. Okay, and you know the components of semen analysis, not just about counting the sperm cells. Okay, there's also a lecture where I've just conducted detailed the approach to semen analysis. Okay, so you can listen to it, and I'm sure it will be of help to you. Then there's something I wanted to forget, but very important, although it's very rarely seen in clinical practice, in a general practice. Okay, it is what we call systolic blood pressure. Okay, the penile pressure actually. So systolic blood pressure in the penis divided by systolic blood pressure in the arm. Okay, so the penile pressure, that's how we calculate the penile pressure. So penile pressure, systolic blood pressure in the penis divided by the systolic blood pressure in the arm. And if it gives you less than 0.6, it indicates impaired blood flow to the penis. That's very important also to take note. Now, let's talk about advanced testing. So when we talk about advanced testing, we have what we call nocturnal penile tumescence and rigidity test. This is where you are tested, okay, using a device, and then throughout the night it's able to record the erections. But this one actually is reserved for medical legal purpose, or those patients that have got a diagnosis of neurogenic erectile dysfunction or psychogenic erectile dysfunction, okay, or medical legal. So this person actually does this erectile, can we know what proof do we have? Then we can do this kind of a test. But these are very advanced. We can also do another advanced testing like the arteriography and dynamic infusion cavernosometry or cavernosography, where I want to measure the muscle, the cavernosa that we talked about in the penis. Okay, what's the size? Does it bulge? Is it functional, or are there some problems? And this one is usually done only in young men, okay, who are actually candidates for arterial reconstructive surgery. Then we can do such kind of an investigation. Then intravenous injection test. This one actually we are testing erection within 10 minutes and supposed to persist for more than 30 minutes, then we know, okay, we are also technically for psychogenic. Then we can also do the neurophysiological testing, where I just want to assess on the physiological aspect, the function, the signs, but this one is more limited to the clinical setting. Okay, so that's what we have to talk about when we are looking at the investigations. Okay, so I hope this has been very easy for you and very user friendly. And this is what we can see when we do the duplex. Also on advanced, we can also talk about the ultrasound, which we call a duplex ultrasound for the penis. And this is what we are able to see. So it's able to help us to see the anatomical structure. Are there some defect? How are the arteries? Are they blocked? Are they working well? So these are advanced aspect of the investigation. Okay, so it's also very important that we can do the aspect. These are the results. Okay, that we can able to see. You can take your time to go through there. But now let me come to the summary. Okay, so what have we done for today? Number one, we have talked about history taking, physical examination, testosterone. These are routine. So your history taking should be focused very well. Genital, urinary tract system. You need to talk about medication, substance abuse, past medical history has to be taken very well. Diabetes mellitus, hypertension, hyperlipidemia, coronary artery disease, chronic kidney disease. Talk about the interview with the partner, of course, with a permission. Talk about libido issues when it is reduced. You may think of to look at the age. If the patient you're attending to is aged, then talk about advanced age. And then if he's young, talk about reduced testosterone. Then the other thing that you should do also always remember is a time course. Age on the onset, duration, progression, rapidity of the onset. Talk about situational factors. Okay, in what situation does this erectile dysfunction occur? Is it after quarreling? Is it after what? So that you'll be able to rule out the psychogenic or is it organic? Okay. The sexual history also. How frequent do they have? Have they been in relationship? Libido, presence of relationship problems with partner, history of sexual trauma. And should we also be quickly to remind you, also ask about bicycle cycling. Also ask also on the aspect of cultural as well on your history taking. That's very, very important. Then one thing also that should help you to differentiate on your history taking, whether it is organic or psychogenic, you may also talk about the following things that you should to ask about. If it is physical, usually the problem is gradual and it's progressive. It is very progressive and it is present in all situations and partners. Even if this man changes a girlfriend, goes to a younger one, goes to a different race, still erectile dysfunction is there. That is physical. Then it is also inadequate response to phosphodiesterase inhibitors type 5, like Viagra. It takes Viagra, but now it's not responding. It has been taking the drugs now, but it's not responding. That usually should indicate to you that that is physical. And then you should also look at better erection in standing position than in lying down. So when he stands, then the penis erects, but when he lies down, there's a problem. And then morning erections are low. This you'll find that these are physical in your history taking as you are asking. Then when it's psychological or psychogenic, usually the sudden is very onset. Maybe after a dispute at home, and usually it is on and off, it's not progressive, and it is in some situations. You find that when he leaves the home and he goes to a girlfriend, then he has got strong erections. That is psychogenic. And sometimes this is where we have got even some beliefs to say, no, I think this woman has done some juju on me. When I'm away, when I go back to my home, I don't do anything. But when I see her, actually, I feel active. So maybe it's the way the communication has been, the way the perceivement has been. But I'll not go much in detail. You can join my psychiatry lectures concerning these issues. I'm sure you'll be able to get them in depth. Then there's good response to phosphodiesterase type 5 inhibitors like Viagra or sildenafil citrate. So they respond very good, very well to these kind of medications. And always they will be going to a pharmacy. So that's psychogenic. So when they don't take this medication, they feel like they can't do anything. Okay. Then precipitating or psychological factors may be positive. Then morning erection suggests that, but always can confirm with psychological etiology. So that's what we have to talk about. Then they do the physical examination. That's very important. And what do we look at the physical examination? Talk about the visual, observe the patient, and check on the genital examination, penile, plex, testicular size. Talk about peripheral evidence of reduced testosterone by checking the breast size in male when they are increasing, and that will tell you reduced testosterone. Also, assessment of evidence of systemic sclerosis, atherosclerosis, like peripheral pulses may be there, okay? Cremasteric reflex, and when it's not there, it will tell you that is psychogenic. Then you do now the labs like testosterone, okay? So what do you do from there? Let's move. We have this, okay? We're going to see this one. So is taking physical examination is diagnostic of local penile disease. Diagnose of what have you found as the local penile. So is it of the pelvic? Is it of the penile? And that is going to help you to make a diagnosis to say, okay, actually, it is what? It is penile. Or it is of what? It is of pelvic. Okay. Then from there, you move from there. You come next, your physical examination and history taking gives you its neurogenic cause. Then you have to take a different step, another step. What do you need to do now? Confirm with more focused evaluation, okay? As I talked about on psychogenic, all those factors, how is the relationship, how is the lifestyle, and continue with focused evaluation. If now you are testing the testosterone there, and you find that testosterone is low, you only proceed for further investigations only when testosterone is low. So when it is low, you have to really ask one question. You have to do the luteinizing hormone, follicle stimulating hormone. So expect either to be high or low or normal. So if it is high, then think of primary hypogonadism. And once you address this primary hypogonadism, then of course determine the type so that you are able to evaluate the chromosome abnormalities, okay, and other genetic conditions. And then if the luteinizing hormone, stimulating hormone is normal or it is low, then think of secondary hypogonadism. Okay, that's very important. And then such you think of the pituitary hypothalamic disorders. So once that is there, then you have to do the what? The prolactin. Okay, order for prolactin hormone. Okay, and once you order for prolactin hormone, then if prolactin hormone is going to be high, consider imaging. That's very important. Okay, then there's positive history of causative drugs. Then try to look at the drugs that are there. Is it safe to remove them? Is it safe to reduce the dosage? And you'll be able to determine based on what kind of drugs that this patient is taking, and you outweigh the risk factor, the risk beneficial factors. Then this test, the nocturnal test, penile tumescence test, is not routine, but you can measure, okay? And if it is normal, it will give you that the patient is having progenic. That's the one you can also use here if you want to evaluate further. You can still come to this one. Okay. Now, when we look at that, this is the summary of approach. Okay. Always remember to evaluate cardiovascular risk factors. Actually, believe that every patient that you are attending to who is having the aspect of erectile dysfunction, treat them as all of them actually, they have erectile dysfunction unless proven otherwise. Okay, so that's what is very important to take note. So task 1, let's see if we have been following. Nitric oxide synthase contributes to erection by A, raising CMP levels that relax smooth muscles and increase blood flow. Blocking phosphodiesterases to increase cGMP levels that release smooth muscle and increase blood flow. C, acting soluble guanylate cyclase to increase cGMP levels that relax smooth muscle and increase blood flow, raising intracellular calcium concentration that relax smooth muscles and increase blood flow. Which one is your answer? Okay, which one is your answer here? Hope you are thinking is soluble by acting soluble guanylate cyclase, because this one actually, it is the one that is increasing the production of the cyclic guanosine monophosphate, which is a potential vasodilator. Okay, so answer should be C. Then task 2. Which of the following are true? An erection is an erection is a sympathetic response initiated by sexual stimulation. Is it true or false? 2, dilation of blood vessels supplying erectile tissue results in erection. 3, nitric oxide causes smooth muscle within erectile tissue to relax, which results in widening of blood sinuses. 4, ejaculation is a sympathetic reflex coordinated by the sacral region of the spinal cord. 5, the purpose of the corpus cavernosa penis is to keep the sponge urethra open during ejaculation. So this is the task as we are going to part 2 next time. So A, 1, 2, 3 are true. B, 1, 2, 3, 4, and 5 are true. And C, 1 and 2, 2 and 3 are true. D, 2, 4, 5 are true. E, 1, 2, 3 are true. So which one is your answer? So you should be able to respond, and thank you very much. I will come you to the next topic. Thank you very much. So the next topic will be looking at approach to a patient with erectile dysfunction part 2, where we'll discuss now on how do you treat this patient after all these investigations. Okay. And another proper investigation I wanted to forget in our setup as Africans, we also use a brazier. If we want to know aspect, is it what in terms of erections? Okay, a brazier also is used. Taken to the bedroom, warm up the brazier, and if there are no erections occurring there, and of course, when they are in happiness, they are in love, and they're trying, they are desiring to have, but it's failing, regardless of trying to increase the the blood flow, because when you put up a brazier, because of the heat, it is expanding the blood flow to the penis, but it cannot still erect. So a brazier also is used and set up in the African setup. So I wanted to forget on that one. So see you next time. Hope you have enjoyed my lecture, and please, I'll be very happy to give me a feedback and ask you questions. Those who are members, you can ask on e-learning platform on my YouTube link. You can still make comments there, and I'll be able to respond. Thank you very much. Stay blessed. And let me end with this quote. I have always said, if you need Viagra, you are probably with the wrong girl. That's according to Donald Trump. So please, if you are moving with Viagra, Sildenafil, Blue Diamond, you always need it, then tell the patient you are probably with the wrong girl. Okay. That's why you want to do it like that. So see you next time. I'll come and explain in part 2. Stay blessed.